Welcome to Longevity.Technology UNLOCKED, where we crack open the science that could help you live healthier and longer, and sometimes even make you think twice about what's in your longevity stack. I'm Phil Newman.
And I'm Dr. Nina Patrick. And Phil, speaking of what's in people's longevity stacks, if you told me a few years ago that the buzziest thing in aging wasn't just a new supplement or reprogramming cells, but GLP-1 agonists, I'd have been kind of surprised.
Yeah, well, of course, we've seen Ozempic and Wegovy and their kind totally go mainstream. They're so popular now that pharmacies can't keep up. And we're seeing all of these new businesses emerging that are getting funded so quickly. Frankly, I'm concerned that they themselves are over-leveraged.
And they probably are. We're seeing people microdosing GLP-1s, taking them off-label. So that's why we're diving into the question today, GLP-1s. Should we all be taking them?
Great question. So we're thrilled to have two global authorities joining us today. First, Dr. Eric Verdin. He's the CEO of the Buck Institute, a world-leading organization in the biology of aging.
And Dr. Jens Juul Holst, Professor of Medical Physiology in the Department of Biomedical Sciences at the University of Copenhagen. And he first discovered and described the GLP-1 hormone. So, gentlemen, before we unpack the science, can you tell us a little bit about yourselves? Jens, let's start with you.
So I'm a professor at the University of Copenhagen. I'm a doctor. I think this is a little bit important for what I've been doing throughout all these years. I've been interested in diabetes and obesity for a long time. Although I started in gastroenterology, I'm still there a little bit all the time. My main interest is gut hormone and pancreatic hormones. So I guess this reflects my original occupation in that direction. So that's what has been going on. But, I'm a university teacher and researcher. That's it.
Great, Jens. Thank you. And of course, Eric, we see each other on the circuit. I can't remember the last event that we were co-located at, but it'd be great to learn a little bit more about yourself as well.
Well, first, thanks for having me. It's an honor to be here with Jens to talk about GLP agonists. I'm a little intimidated by this, but it's great that it's great to be here with you guys. I'm also a doctor, and what you might not know is actually I started in diabetes and endocrinology and training in internal medicine, and did my postdoc at Joslin Clinic studying insulin signaling with Ron Kahn. And eventually, my career went into all kinds of directions, but there's always been sort of a first love of metabolism and metabolic disease. And so right now I'm the leader of the Buck Institute for Research on Aging. I also run a lab which focuses at the interface between epigenetics, metabolism, and immunity.
Yeah. And Eric, of course, there's a lot going on at the Buck, and I'm sure we'll talk about that work as we go along. But I guess as a little bit of a get to know you, I've got a very important question I'd like to ask you. Let's start with you, Jens. Jens, what's the best party you've ever been to?
I've been to several parties, I must say.
Great.
But one of the most amazing ones was really when we received the breakthrough prize in Los Angeles a year ago or something like that. That was really quite overwhelming. It was a very un-European and un-Danish, but a huge experience, and it was a lot of fun, I must say. So it was really overwhelming.
And Eric, what about you? What's the best party you've been to?
Oh boy, you're ready. I'm not sure you want to hear all of it, but
we do. Come on, Eric.
I've been to many parties, but I love live music. For me, that's really one of my other passion, and besides science and aging research, I never miss a chance to go listen to live music. And in particular, blues guitar. And so I've been to many concerts. One of the things that I remember as amazing was a Crossroad Festival that Eric Clapton has every 3 or 4 years. That was in Dallas, and I took my son there, and we spent 3 days just surrounded by the best jazz, blues and rock musicians in the world.
Well, that sounds great. Well, good. So get to know you all a little better. I won't tell you about my favorite party. I think we need to take that one offline. But let's talk a little bit about GLP-1s. And I guess we hear a lot about the subject. But for listeners, Jens, new to this subject, or maybe a little opaque about the subject, what are GLP-1 agonists, and why do we see that they're starting to make the headlines in the longevity space?
So GLP-1 is a hormone. It's a hormone produced in the gut, and there it's secreted when you eat, and it functions to reduce appetite because it's located pretty far down in the small intestine. So it signals abundance, there's enough food there. And so stop eating. And it also slows down gastric emptying and things like that, to put things into balance. So that's the real function of it. And it also inhibits appetite, as I said. And this was discovered quite early. But it took a long time before it was possible to use this in kinds of, as a pharmacological tool. And that was because it also has side effects. So it took a long development, and also it is broken down extremely rapidly in the body. So you had to solve those problems, how to avoid the side effects and how to prepare the hormone in a way that it could be given in a reasonable dosing, first once a day and then once a week. So all of these steps had to be kind of overcome, but it's using the body's own mechanism, that is a regulation of food intake and insulin secretion, by the way. But it's actually secondary to its functions.
And I guess so there's another question that I'd like to ask you just on the back of that. We've seen the most recently approved drugs hitting the market, but these drugs have been in humans for quite a long time now, right?
Yeah, I mean, it was 2005 was the year of the first approved drug for this, and this was for diabetes use. So 20 years this year.
And Eric, how do these GLP-1 agonists fit into the broader picture of lifespan, health span, and aging?
That's a key question, because as your audience will appreciate, there are. I'll just highlight some differences in the aging field in terms of what is a longevity drug, because there's some disagreement at that level there. I take the stance that anything that increases human longevity, even if you start from obesity, for example, is going to be a pro-longevity drug. So anything that will increase lifespan and health span in the population at a global level will be beneficial and will increase people's lifespan. And so in this respect, simply having a new drug that will tackle the enormous obesity epidemic is going to be really important. We know obesity right now is driving a decrease in life expectancy in the US, and I predict this will happen in Europe, as the obesity crisis is not really a uniquely American process. We see it across the world. So in this respect, just suppressing obesity is going to be a really key tool to increase human longevity. There's a second group of people in the longevity field who take a more pure way of longevity, by which a molecule has to be increasing longevity in a somewhat normal individual, and this is the role of GLP-1 agonist, receptor agonist, is a little less clear. There's growing evidence that there seems to be, at least in some model systems, effect of these molecules that go beyond, that are independent of weight loss. And I think this is really where it becomes very interesting. I would argue that most of us are somewhat overweight, even though we might not be considered overweight. And so, I've experimented myself with GLP-1 agonists just to feel, okay, what is it like? And I lost 5 to 7 pounds. So, and I was not overweight to start with. So and I suspect, even that small difference in weight already made a difference in some of my metabolism. So I think it's kind of a blurry line in terms of really what is a longevity medicine. I think these molecules are going to be remarkable in reach, and allowing us to tackling the obesity epidemic. And second, I think there might be a silver lining that goes beyond this, that even individuals who are not obese and not type 2 diabetics are going to benefit from those.
Yeah, Jens?
So I'd like to add that, with this first drug that was approved by Yeta, the exenatide, there was toxicology studies done by the Amylin pharmaceutical company. And so they gave rats and mice exenatide for their lifetime in very high doses. And it turned out that the higher doses they gave them, the longer they lived. So this was really, they were healthy animals, but that's what happened. it turns out that there's a good explanation for this, because what happens is that those rodents, just like people, they eat a little bit too much in reality if they are on ad-lib food. So if you can prevent their weight gain, then you can also increase their lifespan. So that's what happened, actually. But it's very interesting. The other thing I'd like to emphasize here is that if we compare this therapy with bariatric surgery, which I think is really relevant and important, we know now that bariatric surgery given to people that had diabetes when the surgery was performed, they can expect to live 9 years longer from very, very large studies. So you can say it seems to be longevity, but I completely agree that this is because it prevents a number of the problems that may arise as we grow older.
Yeah, and I guess leaning into that, Jens, a little bit, we've seen the clinical studies that have been going on. There's been some very interesting retrospective biobank studies that we've looked at for this. And of course, we're seeing the cardiovascular benefits that these drugs obviously are really changing the way that we're starting to think about on-target and off-target effect. So do you see perhaps in your conversations in pharma that there is this concept of moving away from treating a disease and moving into this preventative sphere?
So yes, both yes and no. So because one of the problems we have is, of course, with obesity, of course, is a number of complications. And if you can reduce that set of complications that are associated with obesity, it follows more or less that you can also you can prolong life and avoid mortality. But actually, there's an interesting study that was done with the GLP-1 agonist. That is the harmony studies that were done, cardiovascular outcomes trials that were done with albiglutide. And it had a very nice effect on cardiovascular risk, the MACE as we call it. It was reduced by 20%. But there was no change in body weight. Absolutely no change in body weight in that study. And that, of course, makes you think, what is going on here? So the conclusion right now is, I think, that there are additional mechanisms. It's not only the weight loss. There are certainly also other mechanisms. And people are talking very much now about what you can call the cardiovascular, renal, hepatic, metabolic syndrome, and suggesting that these are interconnected with a more or less common pathophysiology. And so it becomes more and more interesting to try to see if this is what happens, that GLP-1 interferes with exactly that common pathology. And that is why it is so helpful in all conditions.
And if I can jump into this, this all ties in many ways to insulin resistance. And we've known not only in metabolism and endocrinology, but also in the aging field, insulin metabolism has been known for the longest time to be one of the central pathways that drives the aging process. And I remember the work of Cynthia Kenyon, identifying the DAF pathway, the work in Drosophila, the same thing. All insulin pathways really seems to be central in terms of aging. And, think about metformin, think about SGLT2 inhibitors now, which also are emerging as drugs that target so it just makes a lot of sense to have a drug that targets insulin sensitivity and obesity actually have a potential longevity effect. And I just, since Jens was talking about exenatide, there's a study that just was published, and I think it's Cell Metabolism by a Hong Kong group that actually looked in mice, with all its limitations, but it was a pretty well executed study. They gave mice that were the equivalent of a 60-year-old, and they did not induce any weight loss. And in these mice, they were able to do all of the omics and identified a whole series of pathways that actually seems to be critically involved in the response. And they showed a reversal of aging processes, epigenetic clocks, functional strength, but also molecularly a signature that actually looked like rapamycin, which was quite interesting. And what was even more interesting for me is the fact that a lot of these effects seem to be mediated by the hypothalamus. and in particular a set of neurons in the arcuate nucleus, which are involved in satiety control and so on. So and that data has been shown in humans as well. So there are so many lines of evidence that are, making a lot of sense biologically. It's hard not to look at it and to be hopeful. And this is why I think you're seeing so much enthusiasm from the longevity community about these drugs.
Exactly. I'm glad you brought up insulin resistance being the core problem, and also bringing up a bit about the brain, because there has been a lot of hope around GLP-1s for brain health. And I think you both probably read the Novo Nordisk Alzheimer's trial clinical results that just came out last week, looking at their older diabetes drug, Rybelsus. What do you think this failure means in terms of neuroprotective hopes? I'm still a bit more hopeful because they were looking directly at mild and moderate Alzheimer's. But what are your views on GLP-1 still being neuroprotective?
Should I start?
Yes, let's go with you, Jens.
Okay. So first of all, you have to note that this was with the oral GLP-1, and it was with the old dosing, if you will. With the 14 milligram dose as the maximum dose, right? And so that is I consider that as suboptimal GLP-1 therapy. So it's not so they're right now working on getting higher doses approved, and they're working very hard on getting the 25 milligram dose approved, and they're also looking at the 50 that has been published already with quite impressive results, and certainly also greater weight loss results. So what I'm trying to say is that there's a difference between the different GLP-1 agonists. There's a power difference, a potency or power difference. Right now, I think we can assume that tirzepatide probably is the most efficacious of them. So, I mean, I'd like to see the same result with tirzepatide. That's what I'm trying to go. So, but there are other comments here that should be made. That is, was it a good idea in the first place? So the GLP-1 agonists, the ones that we're talking about, they don't enter the brain. So if you think that Alzheimer's is a pathology that is occurring specifically within the brain, then there is no real reason to believe that it should work. There are a number of experimental studies that have been done over the years where people have been looking at brain sections and cultures and what have you, where you can add GLP-1 directly to the neural tissue, and there are a lot of receptors in the brain. I can come back to that. And there we have seen these positive results. But in fact, in the living human being, GLP-1 does not enter the brain. It reaches the brain via connections in what we call the circumventricular organs, where there are neurons that expose the GLP-1 receptor, so that you can excite those neurons, and they then in turn can influence cerebral processes. So this, I mean, I hadn't expected that there would be any effect on Alzheimer's, except that we have all these observational studies that were positive, of course. But why is that then? So that's where we come back to what we talked about already. So the weight-independent effects, and here I'm particularly thinking about inflammation, and I'm talking about the vascular system, because the vascular system is common also for the brain, of course, and inflammation will also affect the brain if you have a low-grade systemic inflammation. So that's a much more likely mechanism of action. And there we have, again, what I said, the most efficacious drug is the most likely one to be successful. So there is a number of important considerations here.
Yeah, and I guess when Eric,
if I make a couple of points, I think it's important to remember also that Alzheimer's has been called in some circles type 3 diabetes, because many of the abnormalities that we see in terms of type 2 diabetes actually are present in the brain. There are profound metabolic defects in terms of glucose utilization in Alzheimer's. So there's a logical thinking from a mechanistic point of view, but also as Jens mentioned, the epidemiology was there that some patients seems to be doing better, or there seems to be a decrease. One thing that really bothers me about the study is the fact that this was done in people who were diagnosed already. And we know that when you get to the stage when you have a functional cognitive defect, there's already a very significant neuronal loss. And clearly, I mean, no one was expecting these these drugs to be inducing neurogenesis or repair the brain. So I remain hopeful that with better administration earlier and perhaps in a population at risk, you can imagine the clinical trials where we would target the people who are at the highest risk, the ApoE4, the carriers, and really follow them earlier before there are any symptoms. I would predict we're going to be seeing some beneficial effect. Maybe not the cure-all. We just conducted a study with Dean Ornish, even in people who were registering the earliest cognitive defect, and just lifestyle changes, which are associated with increased insulin sensitivity and so on. Just those over a 6 months period, we were able to register a difference. So I'm not sure what happened in this study. I certainly would not turn the page on the potential of these drugs in terms of neurodegeneration in the future.
So I guess we've answered the question that I was going to ask you, because really what you scoped out there is the failures of maybe the drug candidate selection and the cohorts. But I guess what does the next generation GLP-1 brain study look like? If we're going to do it properly, what does that look like?
Higher dose and started early.
Yeah, so
I guess we already have a very large number of observational studies that all support that you can improve cognitive impairment in the patients. And again, I'll come back to the effect on the metabolic effects, of course, because you can reduce whatever we call glucotoxicity and lipotoxicity to the extent that this is relevant for cerebral problems as well. And I think they are. And you can combat atherosclerosis somehow, which is, of course, of great importance, and inflammation again. So all of these factors that you can demonstrably affect with the GLP-1 agonist will also be affected if you have a cerebral problem. So there are a number of good reasons I completely agree with Eric. There are a number of good reasons to believe that this will be effective, but for other reasons than a direct effect on the pathological process in that specific disease.
So I guess we need to think about what we're talking about trials, and we need to start thinking about the regulatory landscape that's supporting all of this. So 12% of US adults now are on these drugs. Meanwhile, you've got companies like Weight Watchers, filing for bankruptcy. I guess as a scientist, Jens, you must get asked a lot of questions about what's happening in this space now. So the perspective that we have on the industry as it is now, from a pharmaceutical perspective, do you see that we are starting to move towards medicating lifestyle rather than disease?
So to me, the most important of all this, and also the entire history that we're in, has been the attempts to prevent complications of obesity and diabetes. That's from the medical point of view where I'm standing, that's the most important. And the problem is huge, because we say that about a quarter of the adult population in our societies have this, what we call the metabolic syndrome, and with that follows a importantly increased risk of cardiovascular disease and stroke and death. So this is what you can demonstrably affect with these medications. This has been beautifully demonstrated in something like the SELECT trial with semaglutide in 17,600 individuals over 4 years. An amazing trial with a lot of information in it. And what comes out of that is that you can actually interrupt this problem. The SURMOUNT-1 trial, the extension of that trial with tirzepatide, showed that the diabetes that occurs in obesity can be almost completely eliminated with tirzepatide therapy. There was a 94% reduction during this 3-year follow-up period in the occurrence of new diabetes. So, there's a lot you can do, and I think this is hugely important. And I was so thrilled to see that the WHO now recommends GLP-1 therapy for obesity and obesity-related problems. But they also discuss, and this is, of course, extremely important, how do you organize this? And that's going to be the real problem, because it has a lot of implications. First of all, who's going to pay? But to me, perhaps the most important is the political aspects of this, because now it's actually almost directly written in the paper. Now it's up to the governments, to countries and the governments to discuss this and find out, how do we do it? How do we do it? Because now we have kind of a responsibility to help these people in our societies that are under an increased risk of developing the complications, because there is a cure. I mean, I have been following this so closely, and back in 2015 or 13, when we started using GLP-1s for obesity, that was liraglutide and with Saxenda, everybody said, "You're crazy, you're out of your mind. This would never work. Nobody wants to pay for it." But that has completely changed, So now it's a really important societal question. How do we deal with this? Because it's there. You can do it, but it will require some real severe activity from the public government.
Yeah, we're seeing from the U.S. side that Medicare is just started covering GLP-1 agonists for obesity. And so, Eric, what do you think? Do you think that the shift is being driven by the drugs themselves and their popularity, or a policy shift, or, like Jens said, just that we really need to give more access?
I agree with everything Jens said. I think there is an incredible shift happening. And I would like to add another dimension to this, is that quite often obesity has been sort of judged on a moral basis, on sort of a moral weakness. If you just stop eating, if you would exercise more. And I think this is a self-defeating approach, because we see the results. Obesity, no matter how much we try to shame someone who is obese and suffering from it, it just doesn't work. And we see the numbers going up. There's a role for the food industry. Everybody recognizes this. There's the degradation of food, increased ultra-processed food. There's a decrease in physical activity. All of those things, I think we need to continue pushing for increasing, lifestyle quality. So educate people and create cities that are walkable. So all of these things are still true. That being said, there's still, no matter how much we try, there will still be a group of people who will become obese because the pressures that they're feeling are too hard. And I think none of us are in a position, in my opinion, to judge whether this is sort of a sign of moral weakness. And I think by medicalizing this and showing the incredible efficacy of these drugs, we're essentially bringing a solution to something that's been an incredible problem. Not only, people always talk about the cost of obesity, but I always like to remind people the sort of personal costs of loss of motility and the disease burden and the shame, everything that comes with it. So I the response quite often that I hear from people when I talk about my advocacy of these drugs is, well, what does that mean? We're going to have 25% of the population on these drugs forever. I have absolutely no problem with this. We use a whole series of medicine forever without any shame. Again, it's linked to the fact that it's linked to obesity. We also assume, I think wrongly, that we are sort of perfect evolutionary product. And I can tell you that what these drugs are highlighting is the fact that we are not. And the obesity epidemic is a reflection of the fact that our genetic blueprint is that of creatures that lived in an environment where food was scarce and where movement was constant. And so now we have been transplanted in an environment where we're not moving and food is abundant, and it's being engineered to actually appeal to our lowest instinct. And no wonder we have an obesity crisis. So in some way, the drugs actually are offering for the people who have the biggest problem maintaining their weight in the face of these pressures, the ability to live a much more normal life. And I think it's quite interesting from my experience sharing, patients' experience with these drugs. They really decrease that food noise and allow people to focus their lives on what all of us want to focus on. So I think there's a big shift in mentality. Stop blaming and shaming obesity, and let's treat it as a medical condition, which it always has been.
This episode is brought to you by The Longevity Show, the global event empowering everyone to live longer and better right now.
So Phil, you're one of the founders. What makes this show different?
Great question as always, Nina. Well, unlike other events, the Longevity Show is open to everyone. We're running 2 tracks and a shared experiential exhibition. It's international. It takes place in London in June this year.
What great timing. London is so much fun in the summer.
100%. And there's the public festival-style experience packed with evidence-based talks from world-class experts on nutrition, sleep, cognition, metabolic health. And then there's the full business track for those executives, investors, and innovators shaping the longevity economy, and for those newbies looking to jump in.
So you're saying it's part science, part business, part experience, and part celebration?
Exactly, Nina. With inspiring speakers, networking, amazing visitor experiences, and even an after-show party. The event is for the longevity innovators, experts, and community all to come together.
So how do people grab their tickets?
Well, just head over to longevityshow.com. Tickets are on sale now, and the early bird offer is still open, but not for long.
So don't miss out. Head over to longevityshow.com and grab those tickets today. Jens, I saw you wanted to hop in there.
I'd like to add, I completely agree with what you said, Eric. And I'd like to add, the question of the imperfectness of our physiology. There are many things that doesn't work too well as we grow up. And one of the things that doesn't work too well is our appetite regulation. But another thing is, for instance, the eyesight, right? We everybody has a pair of glasses. And, nobody questions that we should improve our eyesight by putting on some glasses. So now we are improving our imperfect weight regulation with the GLP-1 agonist, right?
I love this analogy, Jens. That's great. I will add it to my speak.
Well, I guess reflecting what you were saying there, Eric, and, my extrapolation of where we are talking about GLP-1s and obesity, within the context of lifestyle, for me, you just change the word obesity and put in aging, and then you can be making the same arguments. And I guess, we've seen the biotech shares really starting to behave like tech stocks, right? Novo Nordisk was obviously at its peak, Europe's most valuable company. It's gone right back down now, obviously. We saw Eli Lilly hitting a 1 trillion market cap. So do you see, in the context of all of this and the framing of the argument, that GLP-1s and pharma and the investment appetite around prevention is starting to drive up a new context for biotech investing? And, are you seeing any evidence of the biotech winter that we've been in for the last 3 years starting to thaw?
Yes, I do see it. I'm not the only one seeing it. There clearly seems to be some novel degree of optimism in terms of biotech. We should also be sort of realistic in terms of the longevity space is still a very small sliver of the whole biotech world. I deplore this because I think it offers incredible opportunities for growth and for tackling all of these chronic disease of aging. So I hope that along with the unfreezing, thawing of this nuclear winter, in terms of biotech, there will be renewed interest. In some way, we had the ARDD meeting in Copenhagen, which is the largest meeting on aging research, organized by a friend and colleague of Jens, Morten Schubian-Knudsen and Zavaronkov, and it's a great meeting. We had two talks there, which I never dreamt of seeing, and there was the CSO of Eli Lilly and some high-level scientists from Novo Nordisk, both starting their talks by saying GLP-1 agonists are longevity medicine. I should say one of them had a question mark. The other one made the statement. But it was remarkable. It was remarkable because, frankly, big pharma has been staying at a bit of a distance from the longevity field for good reasons. It's a new field. It is populated by some serious people, as I hope we continue to be, but is also populated by some fringe individuals, which, create a bit of a problem for pharma. And so I think the combination of the two, renewed the success of the drugs and the fact that they are actually joining our fight, I think it could mean really great things for the longevity research area. That's my prediction and my hope.
I agree with you there, especially opening up GLP-1, obviously, as opening up a talk saying GLP-1 could be longevity drugs is a huge statement. And leaning into that thinking, that also means they could be preventative. So Jens, do you think from a research perspective that big pharma is going to start swinging more into that prevention space rather than just disease management?
Guys, I'm not so sure. So right now,
Can we all cross our fingers?
yeah. So right now, the way I see it right now, what has been uncovered is that these huge diseases of the civilization, we talked about the metabolic syndrome, the obesity and all that, that this is something that is preventable. That was outside our reach and thinking of just 10 years ago. Now it's preventable. So I think there is plenty to do with keeping people alive, rather than prolonging their healthy lifetime even further, because I'm not so sure that this is what is this, that they will really do this. So that's one reservation I have. The other one, on the other hand, and thinking of the stock exchange, we usually call these stock dealers for hysterical bitches. That's what So, I mean, the Novo Nordisk was selling more than it ever had been selling ever before and making all this money. And that continued completely undisturbed. And still, the stock value fell to a ridiculous low. Okay, that's a different matter. But I'm also waiting for, and Eric also mentioned the omics age. So enormous fortunes have now been invested in the omics. And we know more and more and more about this, and people are now talking about creating a virtual electronic mouse, so that containing all that we know. So if that is true, then it also means that we know things about aging, we know things about longevity and all that. So when is the industry going to look into this, and when do we harvest all that work? All this knowledge that is accumulating, that should be able to, in principle, tell us exactly what knobs to turn in the future. That's what I'm expecting.
I agree. It's happening. And, I used to say that we had to reform medicine because both you and I were trained as traditional physicians, where
Exactly.
I did not have a single class on nutrition, on sleep, on prevention, on anything. We were not trained about preventing disease. We were trained about treating them and curing them.
Yeah.
And I used to say that we should reform medicine. I've given up on this. I think we have to invent a new form of medicine that will function with a different goal. And hopefully, my dream would be to put the rest of medicine out of business. On the other hand, there will still be cancer. There will still be heart attacks in the future. There will never be immortality. I think this should never be part of the discussion. But hopefully there will be a lot less, or for a very shorter period. I think that's really the vision that we have, is that most of us could live, to 90, 95 in good health, and then have a short period of compression of morbidity and then pass. And maybe, in the future, who knows what's going to happen. I mean, I think I'm sort of more focused on what we can do today. And these drugs, I'm skeptical by nature. These drugs are giving me hope that we're going to be able to make much more rapid progress than I thought, 5 years ago.
Yeah. And Eric, obviously, with the buck, there's a lot of, IP being created there. We're seeing these companies being built, seeing quite a number of smaller, earlier stage biotechs partnering now with big pharma. We've seen deals with Novartis and Eli Lilly. And obviously, we've heard of Eroom's law, the diminishing returns for big pharma. So do you feel that there's an opportunity for, the smaller biotechs to be bringing through the next generation here?
Absolutely. And I mean, this is not something that we've invented in the longevity field. This is how it's worked. This is how biotech has always worked. Biotech very rarely becomes a full-fledged pharma. I mean, the fate of most of biotech is really to push the technology that's invented, by the way, 95% of the time, at least in the US and NIH-supported labs, to bring it to a point where it is, it is proven and supported enough for a big pharma to pick up this lab and to actually push what are the really expensive and long-term, long clinical trials. By the way, I think one thing we really hope to do in the longevity field is also by bringing your personalization, and Jens talked about the omics. I think this is a big part of the effort at the Buck. We have a long-standing collaboration with Lee Hood and Nathan Price, building on their effort with Phenome Health, which is really to bring all of the omics to bear to designing clinical trials that are much more precise and therefore much less costly and much faster. And I think, Nathan Price at the Buck, a long-term colleague of Lee Hood as well, has a whole program on what we call the digital twins, or what he calls also the N of one analyzer, which is the idea that conducting clinical trials on a one person at a time and really looking at the changes in parameters. So we're really excited to be pushing this technology, and I think it will change the way we do clinical trials, and hopefully, empower many people to actually conduct more clinical trials, because everyone recognizes we have this incredible sort of basket of technologies, and we have a bottleneck at the level of the cost of these clinical trials, which are long, expensive, and can fail. So I think we have to really rethink the whole process and do it better.
Yeah. And I guess, we're talking about the future and where that's going to go. I mean, we're looking at where we are with GLP-1s, Jens, thinking about, microdosing. Obviously, that's become a bit of a TikTok trend, people stretching out their prescription pens, even people taking tiny off-label doses, buying from online research suppliers and so on. From a regulatory standpoint, should we be worried about this?
Yeah, I guess so. So I was very amazed to see the compounding problem in the United States, because the question I asked myself, where does it come from, all of it? Because we usually consider the production of the peptides, as a kind of a complicated process that is, highly developed. It's kind of a biologics. So shouldn't be possible for everybody to do this, but apparently they found some people that could synthesize chemically these compounds and then sell them at much lower prices. That was, of course, quite smart. But I mean, they are not rigidly quality. The quality is not controlled in a good way at all. So there must be problems, and there has been problems. And actually, in the UK, they said that the major complication of the GLP-1s was a compounded or fake production of it. That had killed several people. So, of course, it's important. On the other hand, the industry has not been. So we are touching on a very interesting problem. That is also the dosing in the long term. And that's where I find the microdosing problem very, very interesting, because obviously people are having benefits from this. I mean, it really helps a lot of people and solve some of the problems. And obviously the pharmaceutical industry has not been the forerunners of lowering the doses and lowering the prices, because that's not how they do it. Mm-hmm. So it's very nice to see that people have taken the matters in their own hands and do it, and have apparently good results. So we really need some studies that look at this and see how far does it go. This.
Have you seen any actual studies be done at these? I guess referencing back to what you said at the very beginning with the Novo Nordisk Alzheimer's, that they used a suboptimal dose. Have you seen studies that have been done at, let's say, instead of these micro doses or very low doses, this suboptimal dose that have benefits?
So actually, so there's an interesting observation here. The redefine studies with CagriSema, which was really very recently publicized, they actually show something about this, because the lesson we learned here is that the optimal effect was not necessarily achieved with the highest dose. The essential problem was to find the doses that fit the individual. And if once that you find that balance, that's when you get the optimal effect also. So it turned, this relationship between dose and effect is an individual thing that needs to be looked at. So the usual way of, everything all doses fits all doesn't work in this. So there's a lot of work to do to find out how we do this.
I completely agree with this. And, another aspect that has been discussed a lot is the sort of muscle wasting effect of these drugs. And I recently saw a study where So the idea is that if you go on these drugs, you will disproportionately lose more muscle mass. And since we know that muscle mass is critical for your longevity and your metabolic health, you could actually be doing yourself some trouble, some harm. And so the study I saw recently actually compared the rate of muscle loss in response to different interventions, including bariatric surgery. And there was nothing unique about these drugs in terms of muscle loss. It's just a reflection of the rapidity of the weight loss. And one thing that I would highlight is the fact also from discussing this with patients and so on, that pharma industry encourages very rapid weight loss. And I would argue that for someone to lose 20% of their body weight in 6 months to a year is probably not healthy.
Yep.
And I would say that probably there should be a second look at doing these trials with much more significant lower doses, which over a 2-year period could actually yield the same results, but with less metabolic consequences in terms of muscle mass. And I think from what my conversation with people in the industry, that there is a interest. And the public are voting with their feet. If they have the higher the dose, of course, the more side effects you have in terms of nausea and heartburn and so on. So people are automatically lowering their dose. So there's a lot of, we live in an interesting period that I call the empowered patient, which is patients are reading about what drugs they can take. They go see their physicians. They're asking for the drug. They're adjusting their doses. There's a lot of the whole biohacking movement, despite its successes, I still view it as a positive force because it means the patients are really becoming part of the solution, which is the only way we will reach optimal health.
So that's one of the reasons that I also think that these drugs should still be prescribed. And that's because there's so much advice that should be given to the patients. And one of the pieces of advice is you should go slowly. So, take it easy. Use 1.5, 2 years to obtain the desired weight, and use that period. That's the important part, to adjust your lifestyle, because you can do it. Because of the effect on the appetite and the reward and all that, you can actually you can determine what you want to eat. I mean, you're in power again. And the other extremely important thing is to start exercising a little bit. And it doesn't take a lot. It only takes, the 30 minutes of WHO recommendations. A walk is enough. Many of these people have an appallingly low oxygen reserve, capacity, and this needs to be rebuilt. So that is really much more important to maintain the muscle mass. But you can also do it. It helps you because of the lower inflammation, the joints are better, the physical exertion abilities are better. Everybody reports that very nicely in the studies. So this is the important thing, and this is where the doctors, should really do something and also recommend a healthy diet, enough protein, enough vitamins and all that. Just like after bariatric surgery, it's as important here.
I love this, Jens, because I think it really, it speaks to, our interest in lifestyle factors, but quite often we don't recognize as much how being obese actually interferes with the ability to exercise, to move. So as you lose weight, for people to really adjust the two together, for me, this is not a sort of a patch onto a poor lifestyle. Eventually, and the same for bariatric surgery. I mean, we know in some cases these therapies fail because people go back and they start increasing their intake of rapidly absorbed food that don't need a stomach. So the same thing, I suspect, will go for these drugs. I think the combination with a change in lifestyle is going to be really important in the long term.
So can we just talking, extending that a little further? So, Eric, you mentioned earlier that you had a period of time taking a low dose of a GLP-1. I've met people at conferences that are talking to their doctors so they can access it. They're perfectly healthy people. And I always remember, Jens, the article that we ran with you, which is saying, they may be longevity drugs, but healthy people shouldn't be taking them. I guess, reflecting what Nina said about the microdosing and the appetite for people to consider jumping in early on this. Do you feel that there is a societal change coming about, or is this just like the experimental biohackers coming through?
I'm still on tirzepatide, 2.5 milligrams. And I'm not saying this in a way to endorse it for other people to do this. I'm in the longevity field, so I'm curious. I do a lot of self-experimentation. Even at that very small dose, I have seen profound metabolic effect. My fasting blood sugar, just to give you an example, went from 97 to 85. That's the blood sugar of someone who's probably 20, 30 years younger than me. My fasting insulin is lower than 2. It used to be higher than 5. So there are inflammatory markers are as low as you can possibly detect them. So for me, in my case, it's more self-experimentation with a low dose, no side effect. I find that it has a profound effect on my taste for alcohol, meaning decreasing it. I used to be a glass of wine a day, and I've completely lost interest in this. So we see, on a population level, actually massive changes in people's interest in fast food. Again, I just want to make sure that your audience does not misunderstand what I'm saying for sort of recommendation that everyone should be on this. I'm a physician. I follow all of my numbers, and I view this as a self-experimentation. But, I get an increasing number of people who approach me, ask me, should I do it? Now, if you are 25 years old and you're exercising and you're in good health and you're lean and you're sportive and all of this, I would say, no way. I'm 68, so it's a different kind of ball game. I'm getting to the point where I'm thinking, okay, I feel good. I feel wonderful. I want this to last as long as possible. It's the same discussion that we had with people about metformin. If you're 65 and you have some mild degree of glucose intolerance and you want to go on metformin because SGLT2 inhibitors, because you think it might do you good, I'm supportive. But it's an informed decision that has to be made with a physician that understands the longevity space, that explains the risks. So every medicine has a side effects, and that's the number one thing that people should realize. And so I think we live in this gray world where there are physicians who will prescribe it to people who are not obese, not diabetic, who hope to get that little edge to stay healthy as long as possible. I think we should be supportive of this. After all, as some people say, I'm not hurting anyone. I can afford it. I'm lucky enough to be able to afford it. And I think we might learn something quite interesting at that edge. But I recognize it is the edge. And again, this is not an endorsement. It's more sort of a reality of the fact that there are a very rapidly growing number of people who are doing this and self-experimenting. And frankly, some of them have come back to me and said, I don't like it. It doesn't make me feel good. I've lost the joy of life. I've lost my appetite. I've lost, there are downside to this as well.
I'm glad you bring up some of those risks or some of those downsides, because we have been talking about a lot of the benefits of GLP-1 agonists. But we've also talked about the effect of muscle loss, potential bone density loss. What are some of the side effects that A, you think have been overblown in the headlines, or B, that really haven't been talked about enough? Either one of you.
So, of course, we have this long list of potential side effects that we need to look into, and some of them are very real. There's problems with people that have a delayed gastric emptying. If they have that already, then they may run into problems with these drugs, and that's something that you have to realize, because this is one of the actions of the drug. So you're interfering with something which is already impaired, then you may have a further problem. Gallstones is another problem that we also need to realize. That's something that is increasing when you lose weight. That has been known for a long time, and this also applies to the GLP-1 therapies. Maybe there's even more, but it's still a rare complication, but it's there. It's something that you need to know. Fortunately, the cancers have gone away. They were very much on the agenda some time ago, but that has gone away. And fortunately, now we see, again, it's observational studies, but we do see that the obesity-dependent cancers, and there are at least 14 or maybe 15 of them, that they are generally improved. There's fewer of them if you are on a GLP-1. And there's a huge number of studies looking at this these days. So that's something that what has recently been brought up and doesn't really seem to go away. That is NION. That is the inflammation of the optical artery. That can cause blindness in some very rare cases. Fortunately, it's very, very rare, but it's enough for people to have. It's there. It's on the list now. It's recognized in Europe, and people can get money if they can run into that problem. And then there is most recently in Australia, they're very concerned about suicidal ideation. And think that this is something that should be brought up. It's again very, very rare, but it's probably real, and like it's real also after bariatric surgery. So there are they're very rare, but there are a few problems that we need to talk about.
I suspect that many of those also can be mitigated by, or at least are dose dependent.
Absolutely.
If you're on 15 milligrams versus 2.5 milligrams.
Yeah, well, I guess my question really to both of you before we move on is, you mentioned, Jens, of course, that these are very, very rare. Sometimes these things are blown up by, newspapers and so on because they want a story. Do we see just, I guess the momentum is so great now that people, although clinicians are studying these things, but from a public mentality perspective, that everybody's kind of moved on? I mean, do you feel that that's happening out there? Do you feel that we should be looking in the rearview mirror a little bit more, or is everybody just barreling forward now?
I don't know what to say to this. I don't know. So you're completely right that the press will pick up these stories and you blow them up. And I don't know how this affects people. I hope that they get other sources of information so that everybody doesn't think that the wolf is out. But no, I don't know what to say.
Yeah. Okay. Well, I mean, maybe let's move on to a slightly different subject, which is in relation to, we've seen GLP-1, what is coming next. And Oppenheimer Equity Research wrote a paper, Beyond GLP-1s, erectile dysfunction as a harbinger of health. They identified PDE5 inhibitors, specifically sildenafil and tadalafil, have been shown to have significant reduction of risks for mortality, cardiovascular disease, and dementia. What do you think about these being perhaps a next wave of longevity drug?
Well, that's one for you, Eric.
We are at a stage in the field of longevity where there are a growing number of opportunities. You've mentioned those two drugs. I mean, they do increase lifespan in animal models. They exhibit many of the hallmarks of things that you want to do increase, nitric oxides in the blood vessel wall. So these are things that we know are associated with health. Again, who should go on these drugs? If you have some mild erectile dysfunction and you're in your 60s, this would be a good argument to say you should go on it. There's not only, you're going to get a benefit in terms of the ED, but you're also going to get potential health benefits in terms of health span and possibly lifespan. I mentioned earlier in the discussion SGLT2 inhibitors, Jardians, family of compounds that are blocking sugar reabsorption in the proximal tubule of the kidney, and having also very, very similar effect to metformin and these drugs, improving glucose metabolism, decreasing the spikes, has been, SGLT2 inhibitors have been shown to increase lifespan in mice and in animal models. They also exhibit some of the side effects that we mentioned for a GLP-1 agonist in terms of cardioprotection, kidney protection. So my prediction, my good friend Carl Flager, who has tabulated, all of the clinical trials that are happening in the longevity space, recently told me there are so many clinical trials that will be read in the next few months to a couple of years that I predict we will, in 5 years' time, we will be in a position where we'll have at least 2 or 3 drugs that have the potential to increase your health span and lifespan. And I think, who should go on what? That's the research for the future. Maybe some of these drugs will work in synergies. All of us clearly aspire not necessarily to a long life, but to a healthy life. And I think this is what the field is really focused on now, is really decreasing this incredible burden of chronic diseases that we associated with aging. Whether we live longer in the process, I suspect the two are really clearly linked, but clearly also what we've been doing so far, which is mostly focusing on increasing lifespan without any respect to the quality of that life, is not working for people. If you ask people, who wants to live to 120, I would say in an audience of 100 people, you'll have 2 raise their hands. And the reason is they know what happened to grandma and to their parents, who suffered from all the indignities of all these chronic diseases. So I think we are at a really moment in history where, for the first time, we increased lifespan. Along with it came this burden of chronic diseases that degrades the quality of our later years. And now we are in the position for the first time to change this equation and help people live healthier longer. And the beginning of a long journey. I think I could not be more optimistic about what lies ahead. And I think at the same time, as responsible physicians, I think we ought to proceed cautiously. There's nothing worse that you could do to take someone who could live healthy until 90 and to actually make them sick by giving them a so-called longevity medicine. And this is where I've struck a somewhat conservative tone in the whole community, because the population will not tolerate that we make them sick with the hope of making them healthier. So the burden of proof for us as longevity scientists is higher than a pharma company curing a disease, because we're starting hopefully with healthier people. We should try to keep them healthy and not give them complications.
And that's why I'd like to return to the effect of the GLP-1s on inflammation and the vascular system, because that's exactly those problems that we have it with the extended life. That's where the problems come from. That's how we get the cognitive dysfunctions of the brain. That's how we get the cardiac disease and all that, because of these disturbances. And here you can demonstrably do something about it with the GLP-1. You can delay this process and reduce it. So, I mean, there's every reason to try to improve those complications of being old, right? And that's what I think is so important.
That's totally true, Jens. And, the chronic inflammation associated with aging that we refer to as inflammaging is one of the big targets of these drugs. And we know chronic inflammation plays a role in type 2 diabetes, in heart attacks, in stroke, in Alzheimer's, in Parkinson. All of these diseases have a common pro-inflammatory terrain, and these drugs are targeting this. So it's hard not to be optimistic that they're going to have global protective effect.
Exactly.
I think we could do an entire episode with both of you just on inflammaging. So we're going to have to save that one for next time. Exactly. Because really that's our hours. So that's it for today on today's deep dive about GLP-1s. Should we all be taking them? Thank you so much, Eric. Thank you so much, Jens, for sharing your expertise and your vision. This was a really interesting conversation.
Thank you.
Pleasure.
Thank you. It was a pleasure.
Thank you, guys. So if you enjoyed this show, don't forget to subscribe to Longevity Technology Unlocked wherever you get your podcasts. Till next time, keep questioning the hype. So thanks for joining us, everybody.